move now to spontaneous abortion. Probably about 15 to 20% of recognized pregnancies will spontaneously abort. Here's our case. A 40-year-old woman grabbed a 3-para-1-AB1, so this is her third pregnancy. She's had one pregnancy that went beyond 20 weeks and one that was a spontaneous or induced abortion. At 9 weeks gestation, complaining of vaginal bleeding, 20% of recognized pregnancies will spontaneously abort. Here's our case. A 40-year-old woman grabbed a 3-para-1-AB1, so this is her third pregnancy. She's had one pregnancy that went beyond 20 weeks and one that was a spontaneous or induced abortion. She comes in at 9 weeks gestation complaining of vaginal bleeding. And this is very common, very common. A urine pregnancy test was positive 3 weeks ago. She initially experienced breast tenderness, and breast tenderness is one of the presumptive evidences of pregnancy, but it's gone. I don't like this. Pregnancy test was positive, initially breast tenderness, that's gone, and now she's bleeding. Now she has not passed any tissue at this point. Let's see how we're going to assess this. Here is a chart that we're going to look at to explore the possible managements of first trimester bleeding. The first thing we're going to do is to do a speculum exam and to see if there is any cervical or vaginal lacerations or lesions, and to identify if the cervical os is open or closed. An ultrasound will tell us, do we have a viable or non-viable pregnancy? Is the gestational sac intact? Have some of the products of conception been passed with some left, or are they all gone? We always need to consider with first trimester bleeding, could it be an ectopic pregnancy? Or could it be a molar pregnancy? So cervical vaginal lesions, ectopic pregnancy, molar pregnancy. If the cervical os is closed, ultrasound shows a viable pregnancy, we call this threatened abortion. Management, observation. If the pregnancy is going to be lost, there's probably nothing you can do to prevent it anyway, because the most common cause of first trimester loss is aneuploidy. If the cervix is closed and the ultrasound shows a non-viable pregnancy, no cardiac motion, an empty gestational sac, that is what we call a missed abortion. Actually, I prefer the term embryonic demise because it's probably already dead. This can be managed a variety of ways. A scheduled D&C, where you aspirate the urine contents, is a reasonable approach. Another would be just to await and let her see if she passes everything on her own. I've had patients who have elected to do that who said they were in labor for 2 days. And that they did not particularly appreciate. The other possibility is they may pass some of the tissue, but others remain. Then she has to have a D&C anyway. So I think a reasonable approach is a scheduled D&C. The other thing you could give is to give misoprostol, prostaglandin E1, to help contract the uterus. If we look at the cervical os and find it is open, it may pass some of the tissue, but others remain, then she has to have a D&C anyway. So I think a reasonable approach is a scheduled D&C. The other thing you could give is to give misoprostol, prostaglandin E1, to help contract the uterus. If we look at the cervical os and find it is open, and if ultrasound shows the gestational sac is intact, she hasn't passed anything yet, but once the cervix is open, it's just a matter of time. This is called an inevitable abortion. Management is going to be emergency D&C, because if she's bleeding, she can lose a lot of blood if you just wait even a few hours. If the cervix is open, some of the tissue has been passed, but the ultrasound shows some is still left inside. We call that an incomplete abortion. This also needs to be managed with an emergency D&C. If the cervix is open, ultrasound shows a clean uterine cavity, no placental.
Untreated. Okay, untreated. Okay, that's the step. Droplets. No way, huh? Nu var jag så aktiv i här. Skin.
Hello, bro. How are you?
All the products of conception are gone. That is completed abortion, and the management.
Good, bro. Just trying to study again, and you. Yeah, I've been studying last week. Been doing good. OB-GYN, getting higher scores in Kaplan. So, are you preparing for step 2 or step 1?
All right, let's look at some pictures. The most common cause of first trimester loss is aneuploidy. We already talked about that. The most common cause is Turner syndrome, trisomy 16. We mentioned that previously as well. 98% of Turner syndrome conceptions are spontaneously aborted. Uncommon cause of recurrent pregnancy loss.
I'm doing some baby steps for step 1. That's good. It all starts with baby steps, and then you can ramp up the speed.
Is anticardial.
Let me know if you have any questions or need help.
An antibody. This is where a woman develops antibodies against the fetal tissues or the placental tissues, and
But my school curriculum doesn't help. We're all in the same boat. School curriculum doesn't help.
Results in recurrent pregnancy losses. This is where a woman develops antibodies against the fetal tissues or the placental tissues and results in recurrent pregnancy losses. We'll talk about that more under thrombophilias. The management for this is heparin, subcutaneous heparin. Anticardiolipin antibody. This is where a woman develops antibodies against the fetal tissue
Keeps me busier now, yeah.
or the placental tissues and results in recurrent is anticardiolipin antibody. This is where a woman develops antibodies against the fetal tissues or the placental tissues and results in recurrent pregnancy losses. We'll talk about that more under thrombophilias. The management for this is heparin, subcutaneous heparin. Let's look at ultrasound in evaluating first trimester bleeding. A common way of looking at the...
Are you studying about antiphospholipid syndrome? No, I'm studying abortion. One of the causes of abortion, recurrent abortion, is antiphospholipid syndrome.
Was a transabdominal ultrasound. And this looks at the uterus and what's inside. Now you can appreciate that you're going to have to pass the ultrasound beam through the maternal abdominal wall. What if you have a big mama, weighs 300 pounds? That's going to be pretty hard to see. So an alternative is to use a vaginal probe. With a vaginal probe, you approach the uterine cavity through the vagina, and it doesn't matter whether she's 100 pounds or 300 pounds, you can see just as clearly. So if you're going to order an ultrasound because of first trimester bleeding, I would suggest do a transvaginal ultrasound rather than a abdominal ultrasound. This is a transvaginal ultrasound, and what we can see here is a small gestational sac. Now this is an early sac. You don't even know if there's an embryo in there. It's too small. You can see a nice decidual reaction, which is around the gestational sac. This is 4 weeks and 1 day. Here we see a nice, round, smooth, fluid-filled gestational sac. Too early yet to see any embryo. Here we see a nice, round, smooth gestational sac, And here we have the fetal pole right here. Now, I don't know where the head is. I don't know where the butt is. So we don't call this a crown rump length. We just call this a fetal pole. If you look carefully here, you can see a round yolk sac. The yolk sac should measure about 4 millimeters, and you should see cardiac motion. This would be a normal appearing ultrasound. Here's a nice ultrasound. You can see the crown rump length right here. Here's a yolk sac and nice, smooth, round, fluid-filled gestational sac. This is 6 weeks and 6 days. This is a gorgeous picture. 11 weeks, 4 days. No question about what's the crown, what's the rump. This is a wonderful confirmatory ultrasound. Now, what's wrong with this picture? We have a large gestational sac. It is 19 by 25 millimeters in size. It is round and smooth. It is fluid-filled, but there is nothing in it. It's empty. This is what has been called historically a missed abortion. Nothing is in there. Embryonic demise is probably a better term. What probably happened here was you had a trisomy 5, a monosomy 8, and you had a cessation of growth so early that you don't even see it. Now, sooner or later, there's going to be bleeding, there's going to be contractions, and the cervix will dilate, and now we then will begin a whole different diagnosis. But at this point, it is a missed abortion or embryonic demise. Look at this gestational sac. You can see it is fluid-filled, but it is not round and smooth. In fact, it is collapsing. And here we see a nub of tissue, probably just residual of a grossly abnormal karyotype. Here you can see an incomplete abortion. You can see that there is tissue within the uterine cavity. There is some of the tissue which is gone, some of it is left. This would be consistent with an incomplete abortion. So a threatened abortion, missed abortion, inevitable abortion, incomplete abortion, completed abortion, always remember, could it be an ectopic pregnancy or could it be a molar pregnancy? And we'll talk about those later. The sequence is probably initiated by aneuploidy. Aneuploidy leads to embryonic death. The placenta starts separating. We get vaginal bleeding. Vaginal bleeding leads to uterine contractions. Over time, uterine contractions will lead to cervical dilation. When you have adequate cervical dilation, you're going to have expulsion of the products of conception. If everything is out of the uterus, we call this a completed abortion. And here you can see the uterine cavity. You can see a clean endometrial stripe. There's nothing left in the uterus. You're going to have by aneuploidy. Aneuploidy leads to embryonic death. The placenta starts separating. We get vaginal bleeding. Vaginal bleeding leads to uterine contractions. Over time, uterine contractions will lead to cervical dilation. When you have adequate cervical dilation, you're going to have expulsion of the products of conception. If everything is out of the uterus, we call this a completed abortion. And here you can see the uterine cavity. You can see a clean endometrial stripe. There's nothing left in the uterus. Here you can see there is a little wider endometrial stripe, but clearly there is nothing left in the uterus. There's no need to take this patient for a D&C. My suspicion is that these diagnoses are probably the same pathological process, but it is just picking them up over time at different points. A threatened abortion can become a missed abortion. A missed abortion where the cervix is closed will become an inevitable abortion where the cervix dilates. Nothing has been passed yet. Over time, it will become an incomplete abortion, and we have tissue that has been passed, but some still remains in the uterus, which over time may become a...
I like OB-GYN, to be honest, but I don't know if it is feasible to match in the US, so I'm also considering the UK pathway. I mean, if you really want the US, do your best and try it and come here. Don't just tell yourself, I can't do it. Everybody could, just have to believe it yourself.
where everything has been expelled. So it's probably the same pathological process, but different diagnosis depending where you happen to pick it up over time. An important laboratory test that you should perform if you do a first trimester D&C is a type an RH, because if she is RH negative, then you want to be sure that you give RH immune globulin or RhoGAM to prevent isoimmunization. Because if she is RH negative, probably the same pathological process form if you do a first, depending where you happen to pick it up over time. An important laboratory test that you should perform if you do a first trimester D&C is a type an RH, because if she is RH negative, then you want to be sure that you give RH immune globulin or RhoGAM to prevent isoimmunization. Let's just summarize what we've said. Our diagnoses are threatened abortion, cervix closed, viable pregnancy, observation. Missed abortion, cervix is closed, non-viable pregnancy, scheduled D&C. Inevitable abortion, cervix is open, gestational sac intact, nothing has been passed, but it's going to come, it's inevitable. Emergency D&C. Incomplete abortion, cervix is open, some tissue passed, some remains, management D&C, emergency.
I had a question in Kaplan that talks about the difference between scheduled D&C and emergency D&C. And there's a woman that has a dead child, intrafetal or intrauterine fetal demise, and the correct answer was give her time. So scheduled D&C, not emergency.
Cervix is open, everything has been passed, management is observation. Now, let's say that she has a completed abortion, but you see the patient 12 hours after. She's passed everything. What may very well have happened is the collagen fibers in the cervix have already started to come together, and the cervix may actually be closed. So open would be what you'd find if you find it immediately after the tissue has been expelled, but if you wait a while, it may very well close. And always remember, cervical vaginal lesion, ectopic pregnancy, or molar pregnancy. All right, and that's the end of spontaneous abortion. All right, this next chapter, 2, is entitled Failed Pregnancy. It's intended to be the most available. Here it is the pregnancy and situation in his. All right, this next chapter entitled Failed Pregnancy. And the topics that we're going to look at is induced abortion, spontaneous abortion, fetal demise, and ectopic pregnancy. The first one will be induced abortion. In the United States, 50% of pregnancies are unintended. Not many are really planned. Of those unintended pregnancies, 40% are aborted. The risk of abortion, morbidity and mortality, increases with advancing gestational age, and we'll look at that in both the first and second trimester. Overall, in the United States, about 1 in 3 pregnancies are terminated by abortion. The maternal mortality associated with childbirth is 12 times higher than with abortion. Most abortions are performed in the first trimester, and the maternal mortality rate is significantly less than if the pregnancy went to term. There's been a lot of controversy about abortion being associated with increased breast cancer. This has been looked at in many epidemiologic studies, and the evidence, I think, is fairly convincing that there is no relationship between. A recent development in 2000, the Food and Drug Administration approved mifepristone, which used to be called RU486, as a medical termination of first trimester pregnancies, and we're going to look at that in a moment. Here we see a lot of controversy and anger over abortion, and I suspect that that will go on for time immemorial. Everybody has strong feelings one way or the other. This is a patient who came with a gun to an obstetrician gynecologist's office because of anger over abortion. All right, the most common first trimester abortion is a surgical procedure, which is called the suction D&C. 90% of abortions in the United States are first trimester, and that is done in the first 12 weeks of pregnancy. Typically, these are done in an abortion clinic. Prophylactic antibiotics are given to try to minimize the risk of infection. Pain relief is given by either conscious sedation or paracervical block. The cervix is dilated with tapered metal dilators. I'll show you what that looks like in just a minute. Or osmotic laminaria. Laminaria are sometimes called laminaria japonicum. They are desiccated or dried out sticks of seaweed which are placed in the cervix, and as they absorb the fluid from the cervix and the vagina, they dilate, and as they open up, they will bring about dilation of the cervix as well. The complications of first trimester abortions are rare, but include infection, endometritis, retained products of conception. Everything wasn't taken out. These are uncommon. The maternal mortality rate is 1 per 100,000. Now, if you look at the overall maternal mortality in the United States, it is 7 per 100,000 for pregnancies that go to term with a vaginal delivery. So this is significantly less than that. This picture shows what a laminaria looks like. It is seaweed, which is dried out, and so it has shrunk. This cuff on this end is to prevent the laminar from going too far into the cervix, and the string is to enhance the removal of the laminaria. This is how you want to put it in. So it goes through the external os, through the internal os. As it absorbs the fluid, it will dilate and become larger, and so will provide then the dilation needed to put a suction curette into the cervix. This laminaria was put in too far. This one was not put in far enough. Laminaria japonicum. First trimester abortions historically were performed using a sharp curette like this. That is not done anymore. These curettes increase the risk of perforation and complications. The current way that abortions are usually performed is by taking a hollow suction curette, placing it through the dilated cervix, creating a suction with a pump, and then aspirating the urine contents out. Medical first trimester abortion uses oral mifepristone. The trade name is Mifeprex, used to be called RU486. It is a progesterone. Suction with a pump and then aspirating the urine contents out. Medical first trimester abortion uses oral mifepristone. The trade name is Mifeprex, used to be called RU486. It is a progesterone antagonist, so it blocks the effect of progesterone, and you recall we talked how important progesterone is to maintaining the pregnancy. The oral misoprostol, the trade name is Cytotec, is prostaglandin E1, and what this does, it brings about contractions of the myometrium. So we have mifepristone, which is a progesterone antagonist and blocks the effect of progesterone, and then misoprostol, which brings about contractions to expel the urine contents. And they have asked on the exam, what kind of prostaglandin is it? And it is a E1. The FDA, Food and Drug Administration, has restricted the use of mifepristone to the first 63 days of amenorrhea. And the reason for that is that the earlier it is used, the higher the rate of successful abortion. And if you go past the 63 days, the likelihood of failure increases. Using it with the 63-day limitation, most patients will spontaneously pass everything from the uterus. 2% will still require the vacuum curettage. So it's not perfect. That is a medical first trimester abortion, mifepristone. This is the advertisement for it, the early option pill.
Show us how you take note from QBank and video for step 2. Okay, this is my I have a copybook. I don't really take notes because notes increases memorization, so it increases your tendency to memorize. I don't like memorization. I like to break things down and understand them well, and then they will get into my head automatically. So what I do is that I put anything I think about here, like in this copybook, and then I never read it again. I just arrange my thoughts about a topic, and most of the time I don't really need reviews. Like, I use questions, you know, to just test myself and see whether I forgot or not.
Fought very hard by those who are. This is the advertisement for most. Reason for FDA, Food and Drug Administration, has restricted the use of mifepristone to the first 63 days of amenorrhea. And the reason for that is that the earlier it is used, the higher the rate of successful abortion. And if you go past the 63 days, the likelihood of failure increases. Using it with the 63-day limitation, most patients will spontaneously pass everything from the uterus. 2% will still require the vacuum curettage, so it's not perfect. That is the medical first trimester abortion, mifepristone. This is the advertisement for it, the early option pill. This was fought very hard by those who are anti-abortion because this takes the abortion procedure out of the doctor's office into the patient's home, where nobody needs.
How much information you writing or you take digital notes? So some of these things I already covered in med school, some of them. But so I don't have a lot of things that I don't know. I just complete what I don't know from the video, and that's it. If I need to break things down, if it's a complicated topic, like I said, I just write it down, you know, for me to understand, and then just get in my head.
Having it done. Mifeprex is the trade name. This map shows the countries in the world where mifepristone has been approved, at least of 2002. You can see in the United States, in most of Europe, in China, and in India, in Canada, and in Catholic countries, it has not been approved and is not available. The second trimester methods, the most common is D&E, which is dilation and evacuation. This is a second trimester procedure. The cervix is dilated with the osmotic laminaria, and the number of millimeters of dilation should equal the number of weeks gestation. So we're going to have to dilate it more than a first trimester procedure. After 14 weeks, the fetus is too large to remove by aspirating it through a curette, and so the fetus is removed in pieces. This is a gross procedure. You take out the arms, you take out the legs, you take out the head, make sure that all of it is removed. If it is done under ultrasound guidance, you have a much higher likelihood of ensuring that everything has been removed. Pain relief is by either local anesthetic, intravenous anesthesia, or a spinal. But this is a more complicated procedure than a first trimester suction D&C. This picture shows the degree of dilation needed for a first trimester procedure versus a second trimester. And so each week of pregnancy, let's say 18 week, that is 18 millimeters, which is a significant amount of mechanical dilation, which can result in trauma. The intrauterine contents, the fetus, is removed using forceps like this. These are called Sofer forceps, and you can see how they will grasp the fetus and pull it out in pieces. You reach in and you pull out a leg, you pull out an arm, and you need to ensure that everything is removed. Dilation and evacuation. The immediate complications would be uterine perforation. That's why it's important that this be done by someone who has experience. Dilation and evacuation. Moved using forceps like this. These are called Sofer forceps, and you can see how they will grasp the fetus and pull it out in pieces. You reach in and you pull out a leg, you pull out an arm, and you need to ensure that everything is removed. Dilation and evacuation. The immediate complications would be uterine perforation. That's why it's important that this be done by someone who has experience and is technically trained. You can leave tissue in the uterus, placental tissue, and have retained fragments. Hemorrhage and infection are always risks, particularly with the advanced procedures. Delayed complications. If you have cervical trauma from too rapid dilation of the cervix, you could damage the fibers of the cervix, resulting in cervical insufficiency. We'll talk about that later. Again, the earlier the procedure, the less the risks and the higher the rate of successful abortion. Notice the maternal mortality rate. It is half that of a term vaginal delivery. So if you look at overall the risks, even with an advanced pregnancy abortion such as a D&E, the maternal mortality and morbidity is less than a term pregnancy. So this is a surgical method. Another second trimester abortion option is labor induction. And here uterine contractions are stimulated by various agents. They result over time in dilation of the cervix. The agents used are varied. Historically, hypertonic saline was used. This is a 3-molar solution which irritated the uterus and caused contractions, or you could use hypertonic urea. This is an intraamniotic injection. You can also use prostaglandins. and it is prostaglandin F2 alpha, which is used for these. These can either be intraamniotic infusion or intravaginal or intramuscular. And all of these bring about contractions of the uterus. Misoprostol is PGE1. Some of the effects of the hypertonic solution is it will result in death of the fetus. And when you have final expulsion of the fetus will be already dead. If you use prostaglandins, they will just result in contractions of the uterus, and you may very well have a live-born fetus, which of course is too early to survive. The induction to delivery interval, how long does it take to bring about cervical dilation and expulsion? It could be up to 24 hours. In many cases, if you're using prostaglandin, they will often inject into the amniotic cavity or into the cardiac expulsion. It could be up to 24 hours. In many cases, if you're using prostaglandin, they will often inject into the amniotic cavity or into the cardiac muscle potassium chloride or digoxin. These will result in arrhythmias and cardiac arrest when the fetus does finally deliver, that it is not born alive. Immediate complications, retained placenta, and probably you're looking at 20% of cases will require a curettage to remove the placenta. Hemorrhage and infection are always risks, and the greater the gestational age, the more likely. Delayed complications are similar to those of a D&E, cervical trauma with resulting cervical insufficiency. Notice the maternal mortality is about the same as with the term delivery. So from a strictly medical standpoint, a D&E is safer for the mother than induction of labor. Now, if one is inducing labor because of a gross anatomic abnormality of the fetus and you want to do an autopsy, then you really need to have an intact body. And so the labor induction would be the way to go. If you do a D&E, you remove the fetus in fragments, and you can hardly do an autopsy because all you have is fragments of the fetal tissue. So that is the second trimester procedure using labor induction. You not have inducing labor because of a gross fetus. The maternal mortality is about the same as with the term delivery. So from a strictly medical standpoint, a D&E is safer for the mother than induction of labor. Now, if one is inducing labor because of a gross anatomic abnormality of the fetus and you want to do an autopsy, then you really need to have an intact body. And so the labor induction would be the way to go. If you do a D&E, you remove the fetus in fragments, and you can hardly do an autopsy because all you have is fragments of the fetal tissue. So that is the second trimester procedure using labor induction. A rare procedure, which has major surgical risks, is doing a mini cesarean or a hysterotomy, or even removing the pregnant uterus intact. There are high risks, both in maternal morbidity and mortality. It is rarely used as an abortion procedure because of these major risks. The main indications would be invasive cervical carcinoma. Let's say you have cervical carcinoma stage 2B, where the treatment would be a radical hysterectomy. If this is identified, let's say at 16, 17, 18 weeks, then one of the procedures may be a hysterectomy. Or if you have uncontrollable hemorrhage, which you cannot control, failed labor induction, that would be also an indication. But this is very rarely done. Notice the maternal mortality is significantly higher than any other procedure, 50 per 100,000. Now that's only 1 in 2,000, but that is far higher than any other procedure. And so this should be used with very, very limited indications. And that's the end of induced abortion. All right, this next chapter, 2, is entitled Failed Pregnancy.
Mr. Shelby, keep going, bro. Thank you, man. I will, inshallah. You watch videos first in a system and then do the QBank, and do you review the previous, just doing Kaplan, your world, QBank, or you just read QBank explanation and move on and don't review it again. I'll tell you, so I didn't attend the OB-GYN. Like, I'll tell you, I'll give you an advice so that you can use it to your weaknesses, like you can apply it to yourself. For example, I didn't attend the OB-GYN lectures or rounds in medical school, so I have a very bad, this is a very serious weakness for me. So what I did is that I opened the QBank, you know, I tried doing questions, you know, just to see how I'm doing, and I saw that I'm doing shit. Okay, I'm doing really bad. So what I realized, okay, I'm gonna finish the QBank all the questions to just see what are the questions asked, what are the high yield stuff, what are the not very high yield stuff. And then when I realized, okay, there are certain topics that are high yield, I said to myself, okay, I'm going to go back to Kaplan, I'm going to watch the videos, and then I'm going to focus on the parts that will help me solve the questions, because I've already done the questions, so I know what is being asked, right? And then I try to eliminate the answer choices to see what's wrong, what is the correct answer, what is the incorrect answer. I learned a lot from the questions, and I'm sure that anything that is like, you know, that I have a gap in, like any gap in my knowledge, in my OB-GYN knowledge, I'll just fill it with the videos, right? So let's say I have, you know, 10 separate what's that? Yeah, 10 separate questions about contraception. I have 10 separate questions about contraception. I gather like separate knowledge, you know, separate pieces of information here and there, but I don't have like the frame itself. So after gathering these information, I go back to the videos, and then it makes perfect sense. Everything starts connecting, and this is the best way to learn, actually, is to do questions and then see. I hope that answers your question. If it didn't, you can let me know. So as you see here, these are like 55%. That is so bad for me. This is, you know, how I like, this is my score, like when I do like random stuff, when I do other like systems like surgery. So I realized, okay, I have to watch videos. You don't answer second? What do you mean answer second? Oh, like it's a second question? I don't understand. Can you elaborate, please? Second part of previous question you don't answer. Oh, like your question? Do you review the previous? You just, oh, okay, gotcha. Do you review the previous? You just doing Kaplan, New World, QBank, or you just read QBank explanation and move on? Oh, okay, no. Once I do the system, I don't review it again. I'll tell you when I review it. When I review it is when I do random questions. Does that make sense? Of course I don't do OB-GYN again. I will not do it again. I'll just solve OB-GYN questions along with random questions. That's why I study these videos very well. And when I do the questions, I do them very well.
Now we move to fetal demise. Have you ever seen a funeral with a small casket like this? These are tragic affairs. This is St. Peter's Church in St. George, Bermuda. This church was originally built in 1612. And when I went behind the church into the courtyard, this is what I found. Here's a grave marker, and here is a little grave marker. Either fetal demise or a neonatal demise. And here again you can see these little tiny grave markers. It's always a tragedy when you lose a fetus. And here we have a birth announcement that was sent out. It's not pink and blue with flowers and with butterflies. You have the footprint of a fetus that did not survive. Here we have footprints also. Now, why would anybody send out a birth announcement? In a twinkling of an eye, this little one came into our hearts and touched our lives forever. Dear friend, acknowledgement of our baby's short life may be upsetting to you. You may think the less said, the better. And isn't that how we often think? We feel like if we don't say anything, then we don't need to. Until now, we didn't know how important it would be for us to tell you of our baby, even though our baby died. You can help us through this difficult time by letting us talk about our sorrow when we feel the need, allowing us to cry when we want, and don't pretend everything is okay. This birth announcement was from an obstetrician who lost her baby. Now, if people didn't know what happened, what would be the first question they would ask when they see her? How's your baby? I think this was a very smart thing to do, to let people know what would be the appropriate things to say when they see. It will take time, but with your support, we will make it. Here's our case. A 28-year-old multigravid at 33 weeks gestation comes to the office stating she has not felt her baby move for 24 hours. After 20 weeks, the most. This is a way in which you can help lubrication if you have a patient who has decreased estrogen.
Gotta go to the bathroom.
or inability for pelvic congestion. KY brand warming liquid. And there are baby short a birth and life to. Until now, we didn't know how important it would be for us to tell you of our baby, even though our baby, everything is people. Here's our case, things to say when they see. It will take time, but with your support, we will make it. Here's our case. A 28-year-old multigravid at 33 weeks gestation comes to the office stating she has not felt her baby move for 24 hours. After 20 weeks, the most. This is a way in which you can help lubrication if you have a patient who has decreased estrogen or inability for pelvic congestion. KY brand warming liquid. And there are many other preparations. Liquid. People didn't know it would be the estrogen. Or pelvic. Now we move with a and the little birth life need question. This ability for congestion. KY brand warming liquid. And there are many other preparations. All right, our next topic and last one in this chapter on failed pregnancy is ectopic pregnancy. Ectopic pregnancy can be defined as a pregnancy with implantation outside of the uterine cavity pregnancy. Ectopic pregnancy can be defined as a pregnancy with implantation outside of the uterine cavity. The most common location is in the fallopian tube, in the distal fallopian tube, but if it's outside the uterine cavity, regardless of where it is, that is ectopic. Most common location is in the fallopian tube. Here's our case. A 28-year-old woman visits emergency department with unilateral left-sided abdominal pain. I want you to notice unilateral pain. If it's bilateral pain, what do you think of? PID. Unilateral pain, you think ectopic. So she has pain. Number two, she's got vaginal spotting. So she's got bleeding for 3 days. So we have pain, bleeding, and her last menstrual period was 8 weeks ago. Amenorrhea. When you have those three things, pain, bleeding, amenorrhea, your presumptive diagnosis must be ectopic pregnancy until ruled out. Her previous pregnancy was uncomplicated, term spontaneous vaginal delivery. Now, she had used an IUD for 3 years in the past. When we think of the etiology of ectopic pregnancy, PID, and pain, notice, here's our case. A 28-year-old woman visits emergency department with unilateral left-sided abdominal pain. I want you to notice unilateral pain. If it's bilateral pain, what do you think of? PID. Unilateral pain, you think ectopic. So she has pain. Number two, she's got vaginal spotting. So she's got bleeding for 3 days. So we have pain, bleeding, and her last menstrual period was 8 weeks ago. Amenorrhea. When you have those three things, pain, bleeding, amenorrhea, your presumptive diagnosis must be ectopic pregnancy until ruled out. Her previous pregnancy was uncomplicated, term spontaneous vaginal delivery. Now, she had used an IUD for 3 years in the past. When we think of the etiology of ectopic pregnancy, PID is one of those. IUDs have been associated with PID. Could that have taken place? Don't know. On pelvic exam, we find the uterus is slightly enlarged. Can you have enlargement of the uterus even though there's nothing in it? Yes, you can, because of the hormonal effect. There is left adnexal tenderness. Could there be a tubal pregnancy? Yes. Now, you cannot palpate a mass, but the quantitative beta-HCG is 2,600 million international units. That's important to remember, because we're going to come back to the beta-HCG number. When you have suspected ectopic, we want to get a quantitative serum beta-HCG. Now, most of the time, ectopic pregnancy is unilateral, but here's an unusual case with bilateral tubal ectopic after natural conception. Generally speaking, once you've got a ectopic on one side, you're not going to get it on the other side. Now, notice where will conception take place? Right here, and we get migration of the zygote. Anything which obstructs the movement of the blastocyst or the morula, and it starts setting up housekeeping before it gets in the uterine cavity, will predispose to ectopic pregnancy. All right.
عربية مش موجود.
هو في ستة بس. يعني موجود دلوقتي.
Let's look at what we're going to talk about. If you have amenorrhea, bleeding, and pain, you must suspect ectopic.
اعمل ستريم صح؟ ماشي. اعمل 7 sets مثلا او
أنا عايز أظبط نومي الأول.
هي دي الحاجات
Presence of tachycardia and hypotension.
هي دي الفريكشن.
هي دي الحاجات اللي بتوقف.
Your diagnosis is ruptured ectopic, and the management is operating room right away. because this patient is going under. Let's say she has amenorrhea, bleeding, and pain, but no tachycardia, no hypotension. Then we look at what's the beta-HCG titer, and does transvaginal ultrasound show an intrauterine gestational sac? If the beta-HCG is less than 1500, then you can't tell whether it's a ectopic or not. The management would be to repeat the beta-HCG in 2 to 3 days. If it was a normal pregnancy, what should happen to the beta-HCG? It should double. If the beta-HCG is over 1500, then you say, can we see a transvaginal ultrasound and intrauterine gestational sac? If the beta-HCG exceeds 1500, transvaginal ultrasound, no intrauterine gestational sac, your diagnosis is unruptured ectopic. How do we manage an unruptured ectopic? It depends on the gestational age. If it is early, we can use medical management using methotrexate. If it is more advanced, we will use surgical